Okay, welcome, and a very good afternoon to everyone for this session. It's a plenary session on health data governance, taking principles to practice. For your information, Asia eHealth Information Network has been actively involved with the development of Transform Health Data Governance. In short, we call it HDG principles, from the drafting stage since 2021. Following that, the DHDG principles were officially released on April 7, 2022. Congratulations to Transform Health. And AHIN endorsed it immediately and arranged a webinar on May 9, 2022. And I'm sure some of you all did join that webinar to disseminate this information with AHIN members within 1 month of its release. Building on that traction that had been steadily growing in the region, following the continuous efforts from AHIN and our partnership with Transform Health, we felt that it might be prudent to work together with specific countries in the region to facilitate in-country dialogue as a means to evolve a wider regional consensus towards health data governance in the journey towards the global framework development. So in this regional roundtable discussion, we would like to focus on the following objectives: to disseminate Transform Health HDG principles to all potential countries, countries sharing on their output from the in-country dialogue. There'll be 3 countries presenting today, and also to discuss with other countries on the requirement of the framework needed to take HDG principles into practice in the region. To you, Jai.
Yeah, thanks, Fazila. So last year, just 1 year down the lane, we had the pleasure of introducing the principles. So that was the first step. The second one was like we started working with the countries, and nobody has any objections for these principles because these are universal and human rights based. But people were asking us, okay, the principles are very good, very nice, but how do we actually put them into practice? That's when we felt like those countries who were interested, and then they were at some point in time, like for example, there are countries like Philippines, Malaysia, and then also Sri Lanka, they have their blueprints. So rather than considering this very important topic as a silo, why not we consider that as part of the National Digital Health Strategy or the blueprint? So that was the idea. Then that is where this selection of these 3 countries, it doesn't mean that we do not want to work with other countries. We felt that I think we should work focusedly with few countries, help them in the process, and then engage other. So that's where we are. Right now, we had this in-country consultations with 3 of the countries, that is Sri Lanka, Philippines, and Malaysia. And then before that, like I would like to also invite Kristen from Transform Health. She will actually also provide the overview. And then Transform Health is also working with other regional networks in other regions. So I think it's also good to know what else is happening in other regions. And then we will have the 3 countries sharing their experience. So let me call upon Kirsten, who is the policy lead from Transform Health, and then Dr. Dennis Batangan from Philippines, and then Dr. Hamad from Malaysia, and then Dr. Udita Pereira from Sri Lanka. And then, yeah, please come over and join on the stage. And please do give a quick 20 or 30 seconds introduction by yourself. Dennis, Dr. Dennis, anywhere? Okay, okay. Yeah, please.
Sure, I'll come in the center.
Yeah, over to you, Chris. Start with this very short self-introduction.
Yeah, thank you, and it's great to be here today. So my name's Kirsten Matheson. I'm the Policy and Advocacy Lead at Transform Health. Transform Health, we're a coalition of more than 150 organizations advocating for the enabling environment to harness digital health and data to achieve UHC by 2030. We work really closely with AHIN in the region, as well as with other regional networks, as Jai mentioned, and also with national coalitions in 6 priority countries, but then also working globally across our coalition partners towards these agendas.
Thanks, Kristen.
Hi, good afternoon. I'm Udita Pereira. I'm from Sri Lanka. I'm representing both my Ministry of Health as well as the Sri Lanka College of Health Informatics.
Hi, good afternoon. My name is Hamad Fadli Siding. I'm from the Health Informatics Center, Ministry of Health, Malaysia.
Yes, good afternoon, everyone. I'm Dr. Dennis Batangan. I'm from the Ateneo de Manila University in the Philippines, representing, of course, the report later on of multi-consultation with the Department of Health in the Philippines.
Thank you, and I'm Fazila from AHIN, and with me, Jai.
This is Jai
So
from
we are
AHIN.
the moderators for the session.
Yes, I think we know each other, most of you at least. Thank you.
Yep, great. Make sure that works. Great, thank you. So, as Jai and Dr. Priscilla mentioned, I just wanted to give some kind of introductory remarks to set the scene a little bit for this work that we're doing, how we're working with AHIN and countries and others on this agenda, and kind of what we're pushing towards. And it'd be really keen to hear from all of you as well as part of the discussion to really get your inputs to feed into this work. So, as part of our coalition objectives, one of our key priority areas we're focusing on is strengthening health data governance and advocating for a global framework which articulates a set of minimum considerations for health data governance regulations. So we're really happy to partner with AHIN around today's session. This is an ongoing partnership culminating today, but also the national dialogues that preceded it. So from the development of the health data governance principles and their launch in 2022, which they already mentioned, we've seen a lot of growing support and momentum for this agenda. So really excited of how we can take it forward, and as Jai mentioned, to really put the principles into practice. So great to see all of you here today to discuss what's needed. I'm really looking forward to hearing from the countries that we have as well, to hear the outputs of your consultations and discussions and what came out of those, and how we can really drive this agenda forward together. Go to the next slide. Very good, thanks. So I think we're all here because we all recognize the importance of strengthening the governance of health data, which has really become even more important with the increased amount of data, health data and health-related data that's generated with the increased digitalization of our health systems. And while this comes with huge opportunities for health and for health outcomes, it also comes with challenges and the need for better governance to really respond to issues around data privacy, around safeguarding rights, to mitigate risks of misuse of data, but also to really support and foster data sharing for public benefit. So there are risks with it, but a lot of opportunities that really highlight why we need those stronger governance systems in place, and particularly regulations for it. But because this has a huge opportunity to really lead to better health outcomes, including increased efficiencies, improved data-driven decision-making, improved health emergency and pandemic response, stronger, more resilient health systems, but really ultimately to help support progress towards UHC goals, and really critical for that to really build trust in health and data systems so that we can really harness that data to really improve health access and outcomes. So if we go to the next slide. So there is a lot of growing recognition and consensus on the need for action on this agenda, particularly not just strengthening health data governance, but also data governance more broadly, but a lot of recognition particularly on the need to strengthen the regulatory aspects of this. So I'm not going to list the details of everything that you see on this slide, but just it shows the images of a number of frameworks and strategies and meetings where this has really come out of those discussions, including, just to name a couple of them, so the 2021 WHO Health Data Governance Summit, this came out of the outcome document of that, and it's also recognized in the Global Digital Health Strategy. So if you go to the next slide. So there's also a lot of growing political and stakeholder support for this agenda. So last year, in collaboration with AHIN, other regional partners and other coalition partners, and working really closely with a number of ministries of health, we hosted a session at last year's World Health Assembly, which showed really strong recognition and support from governments and other stakeholders to really drive this agenda forward. We've also seen the Ministries of Health of Cameroon, Sri Lanka, and the Philippines endorse the health data governance principles, and we really encourage other governments and other organizations to follow suit with that. And more than 150 organizations have signed a call to action letter calling for stronger health data governance regulation and calling for this to be prioritized as part of the World Health Assembly. So next one. So clearly a lot of support for this, a lot of recognition and consensus for action on this agenda, but where do we go from here? So to build on that momentum, while a number of countries are instituting health data governance policies and legislation, there's no overarching consensus around kind of what the minimum or optimal regulations should be, which could really then also support countries. But also, given the complex landscape of what is out there, gaps within that landscape as well, we really believe that there's value in countries and other stakeholders coming together to really learn from good practices, to understand where those gaps are, but also to consider what is needed and what should be incorporated into national regulations to ensure the more effective and equitable governance of health data. And what this will do is really help to build that consensus and alignment across countries around the minimum and optimal regulations to essentially establish a set of minimum standards and minimum considerations for health data governance regulations. However, to then really build high-level political commitment and support for this, we believe that this minimum set of considerations or standards for health data governance regulations should ideally be then endorsed by governments through a resolution at the World Health Assembly, which we're really working with partners and governments around and really encouraging this sort of political commitment and support at the World Health Assembly. But really importantly, it's not about just that endorsement. What does it mean for countries? So we really think that by building this set of minimum considerations for health data governance regulations, it also serves as a really important and useful resource for countries, almost as a guide and a benchmark to support them as they are looking at their national regulations and approaches and how those could be strengthened. So it also really serves as a tool and a resource for countries as well to strengthen their national approaches. And then ideally through national implementation, that would create that sort of binding instrument to hold all stakeholders in the country who are involved in collecting and using health data. It holds everyone then accountable to the responsible use of that data. And really, as I said at the beginning, this would ultimately serve to really build better, improved trust in health and health data systems. Go to the next slide. So, as Jai talked about from the beginning, this builds on the work of the health data governance principles. So we really believe that that regulations, and therefore a set of minimum considerations for regulations, should be based on a set of guiding principles, such as the health data governance principles that were launched in 2022. Those principles bring a human rights and equity lens to the governance of health data and really are oriented towards supporting stronger and more resilient health systems. So they were launched in 2022 and have already been endorsed by over 150 organizations and governments, and really aim to align policymakers and stakeholders around a shared vision of equitable health data governance. They were themselves developed through a very inclusive and consultative bottom-up process. That process brought together over 200 contributors from over 130 organizations to really inform their development through a number of, we convened over 8 global and regional consultations. AHIN was very involved in leading the regional consultations on them. So, and then there was a 1-month public consultation on the draft set of principles as well. So very much informed by a wide range of perspectives and expertise across regions, across stakeholder groups to really inform what's needed. But again, it's, as Jai said at the beginning, there are a set of intentions, a set of guiding principles, but how do we really take those forward into practice through national regulation and in supporting that through the development of a set of minimum standards. So go to the next slide. So building on the principles, an important step in this work, Transform Health and partners are convening a series of multi-stakeholder discussions and consultations on what should inform the development of a set of minimum standards for health data governance regulations, both at national level, the ones that we'll hear from today, what's come out of those discussions, as well as regionally. So today's discussion is one of those. To say as well, we've been working closely with Helena in Africa, who have already convened 2 regional consultations in the region at the Africa Health Tech Summit last month and at the Helena conference just last week. And then working with Rekainsa as well, they'll be convening a consultation in Latin America at the Rekainsa Digital Health Forum later this month as well. And then we've also, for those that aren't present at some of these consultations, we've also published an online survey. I really encourage all of you to have a look at that as well as a way to gather further insights into what should inform the development of these set of minimum considerations. At the end of this, I'll show you the link to that, link to the survey, so please do have a look at that. And then once we have this, all these would culminate into a draft set of minimum considerations, which we would then put out for further consultation to build that kind of consensus, sense check if that's the right direction, identify pieces that are missing, but to really try to garner that support around what those minimum considerations are. Go to the next one. So as coming back to the principles, so we really see them as informing the set of minimum considerations. And we really want to, through these consultations, really learn from, what are the current approaches being employed by different countries? What are some of those really good practices in national regulations and legislation and policies that can be learned from? Where are the gaps in some of that? What are other existing international and regional norms and standards that could really complement a set of minimum standards or minimum considerations? But also to really hear from stakeholders and governments around what should go into a set of minimum standards. So these are just kind of some of the kind of guiding questions of what we really want to hear from all of you and hear from stakeholders. So encourage you to think about these questions as well, because we'd love to hear those perspectives during the open discussion. And if you go to the next slide, just second last one. So while we are working with partners to help convene and to kind of stimulate that discussion and move towards these set of minimum considerations, we realize that government leadership is really critical for this. So it's great to have governments on stage with me today, and a number of other governments that have also been involved in this work and as part of these discussions along the way, but just really can't emphasize enough that it's government leadership that is really critical. It's governments that develop and implement the regulations, so they really need to be in the driving seat, and we're just facilitating this process to help catalyze some of that action. But so we really encourage governments to prioritize health data governance and support the development of a set of minimum considerations for regulations, to participate in the consultations, including really, I think it'd be really important to have a member state consultation, particularly if we're looking ahead towards the World Health Assembly. So really encourage governments to really drive that and working with WHO to request a member state consultation on this, and then ultimately sponsoring and supporting a health data resolution at the World Health Assembly. So I will end there and just say I really look forward to hearing from the governments here today, hearing from all of you, and really look forward to working together of how we can take this agenda forward. Thanks.
Thanks, Kristen. I think that was a very good recap of what exactly happened and also sets the scope for what we are actually looking at. And as I said earlier, AHIN worked in the region as part of the regional consultation. We worked focusedly with 3 countries, supported them to do this in-country dialogues, by which I mean like we encourage them to involve. Usually in such dialogues, it's mostly the informatics people or the digital health people, but then in these consultations, in-country dialogues, we involve a larger set of people, like, for example, someone representing the patient, someone representing the health practitioners, apart from policymakers, the NGOs, the government, of course, needs to be there. And so we had a wide spectrum of participants. So we had these 3 countries doing these consultations and then coming and presenting. So I think we will start with Philippines first. Dr. Dennis, over to you. Please do share your experience. Yes, yes.
Thank you, Jai. No? And thank you for the opportunity actually to participate. And we think that this process of multi-sector consultation goes actually very well now with the governance approach now with this particular. Yeah, I think I can a little bit better. Yeah, thank you, Jai. Yeah, just to give the context, know that we're part of the ASEAN Association of Southeast Asian Nations, and the Philippines is actually contributes, no, because the ASEAN is composed of 600 million people, and the Philippines actually has 117 million in the region. The country is composed of 82 provinces and 150 highly urbanized our cities. And this is just a brief context of where the country comes from. Also, to give another context in terms of the healthcare delivery system, the Philippines adopted the universal healthcare in 2019 under the Universal Healthcare Act, no, of 2019. And I'd like to just highlight here actually the role of e-health, which is actually under the governance pillar of the universal healthcare in the Philippines. This is actually the aspiration in terms of the healthcare provider network, wherein the building blocks, now as we see here on the left, actually are being implemented. Of course, with the use of ICT and e-health in the implementation of the health delivery system. Another context that we'd like to provide actually within the universal healthcare in the Philippines is what we call the progressive realization of universal healthcare implementation, which includes actually the use of e-health or ICT health or digital health under the managerial integration process. The other context that we would like to provide actually is the digital health landscape of the country since it started. And of course, the current approach, no, of integrating digital health in the, in the digital health, no, in the universal healthcare implementation of the country. So the multi-sectoral consultation actually happened online, no, last October 18, and we had 24 participants. There were 6 who came from the government sector. There were 5 who came from the civil society and academic sector. There were 10, a big group from the private sector, and 3 from the multi-sectoral set of donors. And this is the photo of that particular event. So we had an afternoon session, and we'd like to thank Dr. Hamad for joining us in that particular session to provide a preview of what happened in the Malaysian consultation. And I won't go into the details of the objectives and the methodology, but would proceed actually to the highlights of the discussion. We had two breakout groups, and in the first breakout group, the main question was actually what are the key guiding principles and existing norms and standards that should be included to underpin a framework. These are the main things, no, that came out of that first breakout session. First one is accountability. No, in terms of there are two areas in terms of this accountability. One is in the event of data breaches, or who is accountable. No? And the other one is the capacity of the ones managing the system to be able to manage the data that is actually, in a sense, provided by the citizens to a particular institution. The second main item is advocacy and awareness, which actually looks into the how people actually appreciate these principles, and how can they subscribe, no, or support these principles along the way. The third item was on interoperability and the use of standardized and consistent data sharing. And the fourth is on data utilization and management, highlighting the fact that the data that is actually stored should not be stagnant, no? Should be used for more developmental purposes. The next two items are actually on the item of co-creation and patient customer experience and engagement, which looks actually, or there was some discussion on data ownership. No, I failed to mention that in the program that was or in the consultation, there was an input from the Department of Health through Dr. May Velasco. And Dr. May actually highlighted that the health data governance principles are actually consistent with the rights-based approach and the WHO building blocks. No? So as Jai said, these are very, in a sense, universal as it is. No? But there was also a point here in the discussion of data ownership in terms of the citizens' role in data ownership. And I think there was some discussion on digital self-determination versus, of course, the state now having the data and being able to manage them according to the purposes of that of how the data was gathered, no? Or the other main area was sustainability, and for sustainability there were, I think, two areas that was discussed. No, one is actually maintaining these different initiatives related to e-health, because there was some discussion that a lot of projects were actually started relating to digital health, especially by development partners and multilateral groups. But sustaining it after that was as an issue. The other one is actually the articulation of data management framework, meaning once the data is already uploaded and stored, how do you manage it further to be able to use it for research and development purposes? Now, going back to the second breakout session, the question was, what are good examples of current national regulations, registration, HDG areas? And we identified actually several pieces of legislation in the Philippines which were included in the report. One is the Data Privacy Act of, I think this was 2009, which actually created the National Privacy Commission, and which, of course, with that, the guidelines for data protection in the country. There are two pending bills which we thought, no, in the consultation that are relevant or significant. One is the e-health bill, which focuses actually on the delivery of health services. The other one is the e-governance bill, which actually focuses on the entire e-government structure, not only in the health sector, but across the different agencies. And of course, the other one was the Universal Healthcare Act of 2019. There's this Supreme Court ruling in the Philippines that was mentioned as well, the Mandanas-Garcia Supreme Court ruling, which actually increases or which actually grants more fiscal and political autonomy to local government units in the Philippines, which was consistent actually with the universal healthcare implementation in the country. Now, for the part of the breakout session 2 was the question, where are the gaps in HDG areas? No? For the protecting area discussion, the main issue was trust. No? One is who is responsible for the data, or who is responsible for failing to protect the people's data. No? So there was responsibility on the collection and storage of data, and responsibility for failing to protect because of the series of data breaches and hacks that we hear. No? The second is actually trust in the data, no? Particularly in the data collection process, people who are collecting the data. And the third is actually also trust on validation of the data. No? How do you use, or how do you combine data sets if you don't trust actually the source of the initial data set or some of these data sets? I think for prioritizing equity, the issue is related to what we often hear as leaving no one behind, no, LNOB of the SDG. But the main concern is that we don't even know the scope of those who are outside of digital health. No? So there's supposed to be universality in terms of the coverage, but we know that there are still some groups, no, that are marginalized or are outside, no, the digital health radar. No? The participants from the civil society group particularly highlighted the need for participatory approaches to be able to achieve the health data governance principles. And there was also mentioned that some people actually need this data to be able to receive not only financial assistance, but also other types of benefits, no, from the state. The last item is promoting health value, and the main or one of the main items there was on the capacity building activities, specifically on probably having a community of practitioners that can actually support the digital health infrastructure. There was some discussion on AI, no, how the potential of AI, but also the risks, no, of AI, specifically to data sovereignty, and the discussion on data provenance. This was brought out by Dr. Marcelo in that discussion, to ensure data quality, traceability, and transparency, and the role of private sector in the implementation of digital health ecosystems, and also how they can participate in the entire process of data governance. I think that's it for the Philippine presentation. Just to provide some additional inputs, no, that there has been some efforts on data governance in the Philippines through the e-learning platform of the Department of Health. So probably this could be sort of an input as well. But this is actually looking more into the local government setting. And of course, there are also, in our case, no, in particular, the university where I work with, efforts to actually relate digital health to the universal health care and into regular courses in the university. So that's it for the Philippines. Thank you very much.
Thank you, Dr. Dennis. And then I would like to request Dr. Hamad now to share the Malaysian experience.
Okay. So thank you, distinguished fellow panelists, Jai and our delegates. So just a bit of sharing from what we had in Malaysia. We had the Health Data Governance Workshop on the 11th of October, 2023. And during the session, we actually had representatives from the Ministry of Health. So, quite a few of the different divisions from the different programs actually attended the event. And because Malaysia operates a two-tier healthcare system, we also had representatives from the private sector. We had folks from the academia, as well as from the Professional Association of Medical Practitioners. So we did the workshop. So the way we conducted it, it was a focus group discussion where we actually mixed people from the different sectors. So we were sharing, we were provoking one another. So it was quite an insightful discussion. But before we even actually went into the nitty-gritty details of the different principles, we actually had a review of what we already had as a country in terms of health data governance. So we did this by looking at the principle of governance from the framework of people, processes, and technology. So in terms of people, we covered the topics of leadership, roles and responsibilities, data ownership. And then in terms of processes, we looked at the relevant laws, regulations, and policies, our strategic plans and transparency mechanisms. And in terms of technology, we looked at the privacy assurance service that we deploy, the EA approach that we undertake, as well as the semantic and syntactic standards. I will not go through in detail of the review. You should have been at the 11th of October session. So in terms of leadership, we actually have CIOs and CDOs in all the different ministries. This is kind of like a centralized policy set by the government of Malaysia, which we've had since 2009, and we appoint one person as the strategic ICT architect, ultimately responsible for planning, implementation, and monitoring of ICT projects. We have an ICT steering committee that goes together with the CIO. But specific to the healthcare industry, we actually have a National Health Informatics Committee. So this was relatively recent because we decided that we needed a platform where we can actually discuss policies and strategic directions specific to the healthcare, health informatics, and in terms of what kind of data do you actually need? What kind of standards do you actually adopt as a country? And then when we came up with the Malaysian Health Data Warehouse, we realized the importance of having some kind of data access management and a platform to actually discuss between the different stakeholders that were interested regarding the access to this data. So we established the Data Information Governance Committee, initially for Malaysian Health Data Warehouse, but it has expanded in role, and now we have a similar one for our patient registries. And then we formed an Open Data Committee, established in 2021, kind of like to answer the call by the government to actually increase the participation of government agencies in open data initiatives. So in terms of data access and guidelines, we have several guidelines out there defining roles and responsibilities of the different stakeholders within the ministry. And we have set standard operational procedures for data requests in terms of healthcare data. And then the ministry, in the public sector, we have a user access control policy for the different information systems. Now, in terms of data ownership, I see there was a discussion also in the Philippines with regards to this topic. But the ownership of data, the operational definition in the guideline for the handling of management of medical records for hospitals and medical institutions has declared that the physical records are owned by the institution, but the information contained in documents are owned by patients. Now, I can almost hear the certified information system security professionals in the room kind of gritting their teeth at this definition. This may not be the standard industrial definition of data ownership, but in the Malaysian context, this is the operational definition, whereby because ownership connotes a sense of, how should I say, potential financial gain from the transaction involving this data. So that's why it's actually the principle behind it is that the ultimate owner is actually the patients, not so much who controls the data, who collects the data as per what you will find in CISSP's documents. And then in terms of stewardship, the ministry has appointed the Health Informatics Center as a dedicated unit within the Ministry of Health to manage and disseminate health data on behalf of the organization. Now, we have several pieces of legislations, some primary legislations, acts on the Prevention and Control of Infectious Diseases Act that actually grants the power to prescribe forms to the Director General of Health to be used under the Act. And then we have Act 586, the Private Healthcare Facilities and Services Act, that empowers the Director General of Health to actually for statistics from private healthcare facilities. And we have Act 709, which is a more recent Personal Data Protection Act that actually classifies health data as sensitive personal data, which means that it's afforded additional safeguards relative to other types of personal data. So within the Ministry of Health, we have user access control policies, guidelines upon guidelines, and we were actually coming up with a guideline on the consent for health data processing at the Ministry of Health. But since we had the workshop, we have been asked to actually convert it into a bill to be tabled in Parliament. So basically, like most of these guidelines, these policies, these acts, they, especially the policies, the policy documents often contain a set of principles that would explain the rationale behind some of the items in the guidelines. But in Malaysia, they're mostly cross-sectoral in nature. So to have transformed health data governance principles that is tailored to the healthcare data context is to us immensely useful. So in terms of enterprise architecture, standards and privacy assurance, we have our own Malaysian government EA that we model, and then we customize it to the healthcare kind of context. And then we have a privacy assurance service to make sure that we are able to provide the most granular possible, the data in the most granular possible form. But at the same time, maintain the kind of confidentiality required by our laws and regulations. And in terms of standards, we adopt international standards in terms of identifier standards. We're lucky enough to have a national ID to serve as our kind of master index. And then we have terminology standards for the semantic interoperability, as well as the messaging standards for syntactic interoperability. So now, after the group discussions, we actually compiled all the different notes that we got from the different groups and extracted some of the common themes that appeared in the group discussions. So in terms of, we looked at it from the three big groups, protecting people, promote health values, and promote equity. So in terms of protecting people, some of the challenges that were raised by the participants was the risk posed by third-party requests. So perhaps in our context, we do need a stronger and more prescriptive guideline in terms of the do's and don'ts of data sharing. And then there was concerns about the awareness about data subject rights. So this is kind of like a new concept that was brought upon the Malaysian populace when we introduced the PDPA Act, and then overnight, we suddenly had, certain rights on our personal data. But then, to most people, to the layperson, these are still shrouded in a lot of technical jargons, and there were concerns that people may not even be aware of what they should and should not provide, and what should and should not be shared between the different data processes. And then there were concerns about data over-collection. Usually this is something that, a term we use in taxation, but in Malaysia, because we inherited kind of like a very structured healthcare system from the British colonial times. So a lot of programs were tied with certain KPIs, and then even after we review KPIs, sometimes we forget to review the data that we're collecting. So we keep on collecting all this different data, and now with more mature and advanced technologies, there is often the risk of really over-collecting the data. And then in terms of policy, despite the numerous policies that we have, there were still concerns that we are not enforcing some of the policies as well as the standards adequately. And then the uniformity, again, being a two-tier healthcare system, a lot of focus seemed to go around how do we implement certain standards in government facilities, leaving some of the private sector players just going by what is most financially most viable to the company instead of what we actually need as a within the healthcare system. And then it was felt that perhaps there need to be improved clarity in terms of classification of health data. What is personal, what is not personal, what is PII, what is not PII, what is sensitive, what is not sensitive. And then the procedures of sharing this different data. So in terms of strategies, the participants suggested that there should be better feedback and accountability mechanisms, that although that we are sharing some of the clinical and administrative data for research, that we are not actually adequately informing back to the public what they have contributed, how the health data have been used to kind of improve policies and support research activities. And then rightfully so, there was an urge to review data collection to actually be based on reporting needs rather than what can we collect just because. And then it was felt that there should be more specific data sharing policies, especially with regards to sensitive data, interagency sharing, and as well as research data, and enforcement of existing policies, which cannot be emphasized. And then in terms of promoting health values, again, this is something that we really appreciated the growth in demand, especially during the pandemic, and then as we are talking about healthcare reforms, which is the use of non-health data in health context. We find that in recent years, there's been a greater demand, for example, to actually match the visit data that we have from hospitals with other socioeconomic indicators. And so this becomes a challenge because some data, for example, when we want to use tax returns, it's governed by a different set of laws. And because we don't have, the current healthcare law that actually empowers the Ministry of Health only covers certain diseases, for example, communicable diseases. So it's a bit difficult to overrule, so to speak, the other laws. And then there's disparate or disjointed data collection systems. This is as a result of inheritance of legacy systems being deployed in different settings. And this is quite a common theme among the different groups, which is the lag between technological development and the regulatory mechanisms. We're always trying to play catch up. Stable Diffusion gave us Picasso paintings several months ago, and today they can give us almost perfect pictures. But then our regulatory mechanism, when we want to come up with a new bill, you need to have stakeholder consultations, we need to have regulatory impact assessments. It can take years and years before we can actually come up with a piece of legislation. So it's always playing that game with AI, with data sharing, etc. And then there's often heavy focus on short-term policies with quick gains, which can lead to other more important mechanisms to actually ensure sustainability kind of take place in the back burner. And then there's often difficulty in enforcing standards. Some agencies are not equipped with the kind of technical expertise. They're not equipped with the regulatory power to actually enforce the different standards that we subscribe to. So in terms of strategies, the participants suggested that there should be emphasis on data use as opposed to data collection. And it was felt that there should be more agile regulatory development processes, and to actually experiment with research sandboxes where you can actually balance the idea of having health data as a public good with the principle of confidentiality. And then the mainstreaming of real-world evidence, despite the wealth of data that we collect, it is often said that we actually underutilize the data when we come up, even with the most basic decisions of resource allocations, etc. And then to consider federated data structure for new national health data sets, because the culture in Malaysia is that often we go in the spirit of having a centralized repository. Often we go for centralized kind of databases. And this may raise concerns when there are data incidents. So some of the participants actually suggested a federated structure. So in terms of prioritizing equity, there were issues with population subgroup disaggregation. Now, this was raised because, in order to comply with kind of statistical requirements, sometimes we group pockets of communities into bigger statistical groups. And this is despite some, for example, indigenous tribes having an increased increased risk of certain types of diseases, such as certain rare cancers. And these people kind of get lost in the statistical reports that we see. And then there is a lack of understanding about the existing laws that we have. And then socio-cultural and geographic divide. Malaysia, unlike some of the other countries in the region, we are not, a massively archipelago kind of country, but we do have multiple races who speak different languages, and we have foreign workers. And then despite our internet penetration being at 93% as of 2022, we have about 7% of the population who are unreached by the internet. And out of those 7%, actually more than 2/3 are over the age of 60. And people over the age of 60, they fall sick, they go to hospital, but they're not exposed. Perhaps their data are not being collected because of this. And then we also realized that we do need a policy on consent, which we're currently working on. So in terms of strategy, So the participants highlighted the importance of education on patient rights, perhaps in more accessible language, on PDPA, the Personal Data Protection Act, on the issue of consent, and then on the issue of being informed on the purpose of data collection. So it's not just a matter of consent, but informed consent. And then the emphasis on data anonymization, because with manual, when you transition from normal processes to automatic processes, what happens in between is Excel sheets. So with the Excel sheets, there's often lack of anonymization in terms of line listing, and then when you share the data, it gets lost and it gets shared in WhatsApp groups. So there was really an appreciation of the importance of anonymization, which we do have in our centralized data warehouse, but often these things are beyond the control of the central agency when it's being implemented at the field level. Now, also there were suggestions to actually enhance protection for sensitive medical data. So for example, the HIV patient, HIV registry, as well as patients tagged with HIV in the health information exchange to actually protect these people against stigma. So in summary, the workshop that we had, whilst the theme was actually a lot about putting blueprints into practice, but in our case, it's more about the extracting the different principles that we have within our numerous guidelines and our policies and legislations. So with that, I end my.
Thank you very much, Hamad. I would like to request Dr. Udita from Sri Lanka to share the country consultation experience. Thank you.
Thank you, Jai. Ayuban, I'm Udita once again. I'm from Sri Lanka, and today I'm going to talk about our workshop to have a dialogue on digital health governance. Actually, we started this collaboration with AHIN back in 2022. I hope Jai remember we had this convergence workshop on digital health. And the process started from there. And as a continuation of that, we have this workshop on health data governance and digital health for health sector resilience workshop. It was held very recently on 24th of October. It was a whole day program held in the provincial capital of the Northwestern Province, Kurunegala. Usually we hold all our general conferences in Colombo, in the capital, but although people from all over the country take part, it's usually the same crowd. So what we wanted this time was to go more towards the periphery and try to get all the grassroots level stakeholders in to give a different perspective and kind of have a holistic approach to our problem of digital health governance. In this event, it was a whole day program. We had quite a few eminent speakers, including our Director of Health Information, the Provincial Director of Health Services in that province. Also, Christina also joined us through video. Several resource persons talked about the different aspects of digital health governance. And these are some photographs of the proceedings. We had about 120 participants. Photos show different activities we took part, the networking and the active discussions we had on that day. Of health data governance, because these stakeholders may engage in different aspects of governance, but as the concept of health data governance, they had a little idea, so we had to improve their knowledge on that. And what we wanted to do was to identify the pain points of the stakeholders when they were working with health data. And we tried to brainstorm how those pain points can be addressed by a health data governance framework. So these are the participants we had. We had top level, regional level health administrators. Also the middle level management from tertiary care hospitals, secondary care hospitals, primary care hospitals. Then we had representatives from the public health preventative sector, the private sector. We also had our health informaticians and the general public taking part in addition to the ICT experts. We had 3 main activities planned throughout the day. In the first activity, what we tried to was to establish the context, to identify what digital health activities they are happening in these provincial areas. In the second activity, we tried to identify the problems and the pain points. And in the third hybrid activity, we try to map these pain points to the expectations of the stakeholders on how these pain points can be addressed by a digital health governance framework. For this purpose, we arranged the participants into we divided into different categories, and representatives from each category were invited to a panel discussion on identifying those pain points. Led by a moderator and a rapporteur, we tried to extract the pain points they came up with. And in the third activity, in the hybrid activity, we grouped all the participants into several groups, and we encouraged them to discuss and come up with strategies or mechanisms on how we can address those pain points through a governance mechanism. So these are the kind of pain points that the top level administrators mentioned. And not only them, most of the participants were concerned about this first aspect, the trained cadre or the capacity. Do we have the capacity to administer digital health solutions as well as their governance? So that was a recurrent aspect that came up. And they were concerned about the lack of funding and budget lines, specifically for keeping the hardware and software up to date to minimize the risk of data breaches. And the top-level administrators, top-level administrators were concerned that even when the resources were allocated, the middle-level managers did not fully utilize those effectively because there was no proper planning. And haphazard implementation caused difficulties in governing generated data. And some of the national data gathering mechanisms, they did not facilitate regional oversight. So for example, like the data is generated from the peripheral ground level activities, but it goes straight to the central level, but with little oversight or feedback for the regional level administrators for them to access those data and plan activities in their region. So still a lot of barriers still exist when trying to exchange data between the health ministry and the other government agencies. When it comes to the middle level managers, they were mostly concerned about the ad hoc implementation of digital solutions and data collection programs by various agencies. For example, central level agencies implement multiple programs, and they collect similar data sets. And the work of those collecting data is duplicated across those programs. So this was a very much a concern, and it was difficult for these middle-level managers to motivate the staff to collect more and more data from these number of additional programs. Yeah, and also they were concerned that even the existing general laws regarding data, staff did not have a full understanding or idea how they are applied into the health context. In the preventive sector, they were also reiterated the concerns of the top management that there is a little oversight by the regional level when collecting national data. The regional managers felt that they were not involved in the decision-making process. They were rather more concerned with collecting the data and then implementing whatever the recommendations from the center based on that data. They also confirmed that better coordination and data sharing between central health level agencies would reduce the burden of data collection on the community health workers. Now, since health is multi-sectoral and especially in the preventive sector, non-health data is essential for most of the effective interventions. So still there is no effective mechanism for intersectoral data sharing in our country. The private sector, of course, they felt that they had more advanced when compared to the state sector, but looking back, they were reflecting that most of their systems are not trustworthy enough to handle sensitive patient data. They were concerned that sometimes physicians were reluctant to use digital systems, mainly due to taxation and other financial reasons. And data sharing between the private sector and the government sector is very rudimentary. And the private sector, of course, they were willing to push for the electronic health records to be legally binding. The general public representatives, they were concerned that while we have implemented many electronic medical records in many institutions, patients still do not have direct access to their own data. And we have these siloed EMRs implemented in different institutions, which prevents the patients from seeking a second opinion. For example, if my data is held in a EMR, there is, and all my investigation data, my X-ray data, everything is in the EMR, but there is no effective way for me to take that information to a third person or another doctor to have a second opinion. So rather than digital solutions facilitating patient's choice, it seems to be limiting it. And as a result, patients still do not see the full benefits of health data. Okay, this is the Mentimeter session. We had for the participants' feedback. We asked them, what does the phrase digital health governance mean to you? And they were mostly concerned about the data accuracy, the management, the data security, and accountability, transparency, confidentiality. Those were the issues they were most concerned with. When it comes to if there was a governance framework guiding you to solve the problems you mentioned above, what are the high-level domains aspects you should address? Again, it was the capacity building human resources came up again very high on the list. It also included privacy, interoperability, ethics, data security. Those are the main aspects raised. Okay, looking at the way forward, I just need to remind you that we had this session very recently. So these data are generated from the participants. We did not fully analyze them. So the results are amalgamated rather than analyzed. Okay, so these are very preliminary data. What they felt was when we are trying to implement a health data governance framework, some background aspects must be thought of and taken care of. One is developing the capacity or the training, so that both the capacity for the digital health and the health data governance is there for people to take over this aspect when it comes to health data governance framework. And we need to identify budget lines so that our governance frameworks and our governance mechanisms are sustainable. And we need to adhere to the National Digital Health Blueprint so that governance becomes easier rather than a haphazard implementation. So developing the framework itself, we need to facilitate boundaryless information flow. Information, they felt that the information consumed and governed by the entities close to their original data source would lead to more equitable and effective governance of the health data. And we need to establish and ensure adherence to policies, standards, and trust mechanisms. We need to adapt the general data protection laws that are in force to the health domain so that it safeguards individual liberties, but also while maximizing the public benefit. And they wanted a governance with feedback. That means an inherent feedback mechanism to keep the users engaged and motivated. And also, they called for collaboration with other non-health government agencies so that we have a collaborative effort to use and maintain the health data. That's all from me. Thank you very much. Thank you, Jai.
Yeah, thank you, Udita. I think now we are done with the country presentations. I mean the consensus and the outputs that came out of those country dialogues from Sri Lanka, Philippines, and Malaysia. Now we will have some Q&A. We already received some questions, so that we will also post it to the panelists, and then of course anyone else also welcome. Then we will also have a chance for other countries. I know many other countries are also there. They're working on the National Digital Health Blueprint, and you are also welcome to actually give the inputs. And if you have been working on data governance in your country, like please feel free to welcome and share your inputs and feedback. Maybe we will take on the questions right now.
Can I start with the first one?
Maybe the first one.
Yeah. I have a question for all three panelists who presented the country dialogue, I think. Just a very brief one. Building on this momentum, where do we go from here? So a quick answer from Philippines, Malaysia, and Sri Lanka before we open to the floor.
For the Philippines, I think the next way forward is actually integrating this in the Universal Healthcare Implementation Guidelines on Digital Health, because we're on that phase right now, wherein the Universal Healthcare Implementation is actually moving in terms of its preparatory and organizational phases. So there's opportunity to actually embed this more and more into these processes and, of course, guidelines.
So in Malaysia, we're actually in the midst of reviewing and amending several laws. Many are not specific to healthcare laws, but they actually involve healthcare data. So laws such as one on data sharing, we have an Omnibus Act for data sharing, and then we are reviewing, that one is a new bill, and then we are reviewing our Personal Data Protection Acts. So these will all affect healthcare data, the sharing of healthcare data. And we've also been asked to actually introduce a bill on healthcare data consent. So as a result, having these principles in mind, we are actually, representatives from the Ministry of Health can actually come into, the regulatory kind of discussions and to actually be better guided in terms of contributing our inputs regarding what should we get from the law, and what are we trying to protect. And how do we extract maximum value from the data that we have.
Thank you. I think Sri Lanka is at an advantage because we are still at a very early stage of implementation of our digital health systems. So I think what we can do is we can learn from all of your experiences and bring that experience to the development of the digital health governance frameworks. And since we have a lot of buzz generated around our blueprint these days, it's an ideal opportunity for us to build the governance frameworks onto that blueprint, so that all the governance is also in that plan.
Okay, we have received some questions. So these are open to the panelists, and then we also take some questions from the floor. We will go with the ones which we have already received, just a couple of them, then I will come over to you. The first question is, which organization is the best to manage health data? This comes from Dr. Chansali from MOH Lao PDR. So anyone would like to answer? Which organization is best to manage health data in the country? Of course, this could vary with the context in countries, but then but maybe you can relate to your own countries. Maybe that's easier.
As I mentioned in our presentation, our participants in that discussion, they felt that a MOH-led initiative that works with other government agencies would be the best position to handle health data governance.
Thank you, Udit. Anyone else?
In terms of Malaysia, the norm is that the data owner usually manage their own data, and I think that is a kind of good principle because they understand the implementation, they understand the intention behind the collection of that data, and they're better guided in terms of who to consult when there is a change in terms of the data sharing process, etc. But I think now we're also talking about data trusts where you can have kind of like a legal arrangement whereby you can actually contribute certain types of data and have it available for the use, in terms of research, policy, etc.
Just to add to that, so I think within different countries, obviously there'll be different setups of how that is managed, but I think really important is it's the governments themselves being in the lead, because the governments have the responsibility for setting the legislations and regulation in a country which should govern how data overall is managed in that country, and then how the different stakeholders operating within the country need to abide by those laws and regulations. So I think the ultimate is the government. And then when we're looking at health data, my initial response is the Ministry of Health, because I think, but taking an all of government approach, because there are a lot of those laws and regulations that will cut across different sectors, but really important to look at, and it was good to hear this came out of a lot of the conversations, the specific role and sensitivities around health data, which need those added protections as well in place. So while there is an element where it's an all-of-government approach, but really within the governance of health data, the Ministry of Health really taking that leading role. One thing that came out of some of the discussions today, just to bring in another regional perspective that came out of the first consultation we did in Africa, was that a lot of countries have data protection acts, but not a lot of them go down then to the next level of health data specific and what that means within the health sector, or on the other hand, some aren't fully implemented. So yeah, so I think it's an all of government approach, but then also looking at, the role other organizations play as well. And I think both regionally and globally, like the WHO with their norm setting function as well, can, not in terms of managing data, but can play a role in terms of working with governments around, as we've kind of put forward, of developing those minimum standards to help kind of support of what should be in those regulations.
Thank you. I think the management of data is as of now, no, I think it's the prerogative of government, because there are already legislations regarding that. But I think the issue also that is being raised is accountability. Now that citizens have sort of entrusted their identity, and even beyond, data over collection is common in a lot of jurisdictions. So you've entrusted a lot of your personal sensitive data to the government or to the state, and the state would have the duty to protect it against harm, so that you are not harmed, in any way, because that is the role of the state. So the discussion now also revolves around not only accountability, but how far can the state or government protect and be accountable for the data that is so the tension between the individual and the state under, for example, a rights-based approach is still there, and probably will have to be addressed. One observation that we had in the Philippines is that a lot of the regulations or laws were on data privacy, and there are very few laws that actually look into data ownership, because there could be some nuances as well. Now, when you when you look at data privacy and data ownership in terms of how to manage data with those probably conflicting perspectives.
The second question came from Manisha from the National Resource Center for Electronic Health Record Standards, the Center for Development of Advanced Computing India. Her question is, how do you balance on need-based data collection versus long-term plan of data usage? Anyone would like to take this question?
So hello, thank you for this session. It was wonderful. And this question was particularly for Hamad, where he said, you need to have a balance on the amount of the data that you are collecting, the necessary data for the purpose. And then the next slide was stating the challenge where we are not thinking beyond the immediate use case and how do you use this data for the long-term purposes. So how do you balance it? What could be the checks and balances for it? That was my question.
I think I began that slide with the sort of kind of historical background of how, in terms of the manual process, we were used to having certain targets that we want to achieve in public health. And as a result, as the years accumulated, we end up with more and more variables. It's often easier to add columns to your tables than it is to reduce the number of columns when it was manual. And this somehow got carried over even when we transitioned to digital solutions. This habit, it's definitely difficult to kill. And what we're now seeing is that, for example, in the management of patient registries, now we're seeing a transition whereby people are more relying on, they call it e-registries or electronic registries, whereby you use secondary data that's been collected elsewhere. I think Sri Lanka brought the same kind of point as well about really identifying first what you can derive from existing data collection ecosystems before adding on new data sets. Of course, in certain cases, for example, rare diseases or very specific quality kind of monitoring systems, you cannot find this data in our routine healthcare data collection systems, and that's where we have certain types of registries that we collect. So in Malaysia, what we do is that we actually create the kind of like a technical committee, several of those actually. One to look at the business side of things, the National Informatics Council, and the other one is actually the ICT Steering Committee. So and then we have different programs within the Ministry of Health represented in those committees, and they kind of guide whenever there's a new system that wants to be created. So these people in power actually look for the alignment between the data need and then the impact on the staff on the ground, and then that's how we allocate the resources accordingly. And then now that we have the data warehouse, we have the health information exchange, it's much easier when we have a well-documented data catalog for people to actually go through the catalog and see what is already there and what needs to be collected. And in terms of prioritizing which clinical domains do we prioritize in terms of data collection, we're also coming up with guidelines for that purpose. Of course, they need to be guided by several principles in terms of the disease burden, is it significant enough? Can we offer interventions once we have collected the data? Because there is no point in collecting data if you do not know how and when to provide those kind of interventions. So I hope that answers the question.
Yeah, thanks a lot, Ahmad. I think we have a question from the Ministry of Health, Bangladesh. Engineer Roy, over to you.
Actually, my question is to Malaysian presenter. In his presentation, I have seen they are implementing the federated data structure for the patient data. So how you identify uniquely patient with this federated data structure? So for understanding, now in federated structure, you resize the data in the distributed model. So how you identify uniquely patient with this federated structure? Thank you.
Yeah. So in Malaysia, it's not so much of an issue because we have a national ID, and even newborn babies, they get issued a special type of unique identifiers, which we then link to their ID after the birth is registered. So that is not so much an issue, but then for us in Malaysia, the challenge is more on how do we exchange this data between the different institutions, because when you have a master patient index that is also your national ID, which you can use to actually check your benefits, your tax returns, even your exam results on government websites. So our challenge is how do we assign a separate kind of digital identifier that corresponds to each unique ID. So I'm afraid, our experience may be slightly different because, having the ID in place kind of helps. But now, because we realize that a lot of the systems are actually being deployed on mobile applications, etc., the Malaysian government is actually introducing a common digital ID as an authentication kind of platform for these different applications.
Thank you.
We also have another question from Bangladesh, that is from Aminul. His question is specifically to Kirsten. Kirsten, Aminul is asking, what do you mean by minimum standard? And then when we talk about cross-border sharing of information, then what happens to the national data governance policy? Am I right, Aminul, or if you want to explain?
Data privacy, national data privacy policy, yes.
Yeah.
1 minute. Okay, just to preempt, maybe let's not talk about minimum standards. Maybe we can talk about minimum components, maybe. That makes it easier because standard has a very specific connotation. It can mean something else.
Yes, yeah, I was just going to clarify that actually, because we've played around a little bit as well with how we term this by minimum standards not meeting the definition you're talking about with standards, but in terms of what is the minimum that ideally should be within national regulations. So, and we even discussed as well, is this resource or what should be developed a set of almost template regulations, but then realizing it's a very national process in terms of what national regulations and legislation look like, but rather it's more to identify kind of what's the minimum, but also what's the optimal that should be within national regulations that can help guide that. So by saying minimum standards, it's meaning more of kind of what are those minimum components or considerations that should be across regulation. And also by building that consensus across countries around what that minimum and optimal looks like, that also then supports with that alignment to facilitate better that cross-border data sharing, et cetera, which this issue actually came up a lot at the Health Data Collaborative conference that was organized in May earlier this year, which looking at kind of the differences in types of regulations across countries created a barrier then to countries being able to share data, which is, the pandemic, but even before that, showed how important that is to address health emergencies and other issues. And so by having that agreement around what those kind of minimum considerations could be, that also supports with some of that alignment, but needing to ensure obviously that there are the right protections, not only with that data sharing within countries, but even more so with other countries as well.
Two countries needs to be aligned with some places that they agree upon that, okay, we can share the data that under some rules or some regulations, right?
Yeah.
So do you know any rules exist till now? The cross-border policy exist?
Currently, unless otherwise, the countries have a kind of a bilateral arrangement. It is not. But then, like for example, European countries, as part of the European EU health data space, they are looking at actually sharing. Already some part of it is implemented. For example, the prescriptions, the dispensations, that is already implemented. And then they're also talking about the patient summary, not the entire electronic health record. But then they also specified which countries' information, if shared, is accepted by which country. So that is also still in the process. So unless otherwise we have something like a grouping, like maybe for ASEAN or SAARC or something like that, if we have such kind of an arrangement between the countries, right now I'm not aware, except this particular one. One more thing to add is, like for example, in India, of course the telemedicine has been happening, like from India, even Nighthawk teleradiology has been happening with the hospitals in US. But when the government released the telemedicine practice guidelines during the pandemic, specifically they didn't talk about the cross-border sharing. So this is something that I think is done on a very case-to-case basis, right now at least, from what I am aware.
Yeah. Perhaps to add, what they have been pointing out is actually the vaccination data. Because with the pandemic, we started recognizing the vaccination records and data from all over, following a certain set of standards. And even the products, the vaccines, which were all under EUA, were accepted as part of the vaccine that was received by this particular individual. So I think but it had to go through the pandemic experience before countries start recognizing the value of accepting data, particularly in this case vaccination data, to allow entry of other citizens in the respective countries. I think there's an ongoing work now to be able to expand that that sort of I don't know what you call it, interoperability of data, at least on vaccination, so that it can expand a bit further, so that it include probably other data elements. Thank you.
No, I think about this cross-border, I think the pandemic itself has opened up this and made it possible, and it all started with the vaccination about cross-border. But I think many countries now who are moving into health tourism has also opened up on cross-border sharing by using the International Patient Summary. And lately also we have heard for the next Hajj pilgrimage for next year, I think Arab Saudi is also requesting data from all countries for the pilgrims who come in. So you can already see cross-border sharing, yeah. It's just one question, maybe this is to the floor. You know, we always, every country will present this challenge of data sharing, inter-agency, intra-agency, intersectoral. So it's always mind-boggling. Why can't we share data? So maybe someone from the floor can answer that question. You know, we anonymize data, but why are we so reluctant to share data? I've yet to get the correct answer. Why can't we share data? Anyone? For the purpose of research, for the purpose of innovation, for analysis. We have the same problem in the country. Even from within the Ministry of Health, we have the problem. So I don't know, maybe there's something for you to think about.
Okay. It's like it depends on what data. And then what is in it for me? I remember just a couple of weeks back, I was in a session in the World Health Assembly, and there was this senior official from one of the countries. She said there were an agency in the country who collected very sensitive biometric information from people. And people voluntarily gave that because they were promised, I think, $70 per person. Of course, they didn't get the $70 and their biometrics were taken. But if you look at it, what is in it for them? Are they getting something out of it? I think a lot of our data is collected, for example, for visa processing, right? They take everything, all our details, our qualifications, bank accounts, whatnot, everything is with them. And we voluntarily give because we need a visa. So maybe something similar, like, for bank also. So I think it depends on what is in it, what is that we get out of it. I think if the value is perceived, I think that's the answer. Like I do not have a very straightforward answer, but this is how I feel. I have given a lot of information which I would consider it personal because I need that. Whether any one of the services which I get it from the bank or a government or any other agency. So that's how things work. Yeah.
I just wanted to add here. We've been working on some countries, exactly answering the same question about why people will be sharing data, because I was about to ask this question before Christine addressed the point around in the entire data governance cycle, a critical aspect is access to data, whether people share data within departments, within countries, among countries or not. One of the things that we did successfully in a country is, I'm not going to name the country because it's still an ongoing process, is it's more around, say, per se, One Health data. We want the Ministry of Health or the National Public Health Institute wants data from different stakeholders or different departments within the country. Aspect that we introduced is, along with signing of data sharing agreements, we ensured that there is personal interaction between the leadership of both the units, number one. Number two, like Jay said, who gets what out of it. So we created, it's in the process, we are creating a data governance and a data curation unit, which receives the data, works on improving the quality of the data, and the department, the owner who shares the data, gets the quality improved data in return to what they're sharing, right? And whatever insights that this department generates, we also share a copy of the insights with the data owners so that they get some value out of it. So I'm not saying this is what is ideal, but there are a lot of things that we can do something very similar to this. And there are some countries which are adopting this as well.
I think I'd just like to add on and actually perhaps look at the question from a slightly different perspective. I think it's not so much that we are reluctant to share data as though this is a newly developing thing. Because, at the essence of being human, we're all tribal, we're all territorial, we want to guard what's ours. But then what has changed is that the type of data that we're sharing. So previously, in order to manage vast amounts of data, you would need some statistical tables. But now we're sharing, very granular level kind of data. So that's why it's such an issue. But in order to maximize the usability of data, sometimes you need to provide that kind of granularity. But then, it's just there. Your name is just there next to your diagnosis. So that's why, we're having this conversation, it's becoming more common, and it's just going to get, it's going to be part of, now when you sign up to certain websites, you just, share the data from your social media profiles. It's going to be so common. And, I always think about whenever I face this question, when the Greeks first saw that the Persians were wearing trousers, the word that Herodotus used was the Greeks had to endure the sight of trousers, because nobody wore trousers back then. That was the greatest contribution of the Persians to the world. And now we're all wearing trousers. So it's a bit like that.
Yeah.
Yes, sorry.
Yeah, I have one comment. In my point, actually, to your questions, maybe there is 2 to 3 points why we are not interdepartmental, we are not going to share data, or we are not willing to share data. Maybe in some cases they want to share data, but the fact is the completeness and accuracy. So maybe if I am going to share data, maybe there is my fault that I'm not collecting complete data or complete of data. So if I share someone may raise finger to me. You are doing something, but you are not completing it. Number one. Number two, the policy. And it should be a government central policy framework to sharing data. So in many countries, we are missing that. This is why actually we are not willing to, that much willing to share data. And in another point, what we have figured in my point, every point of data collection is related to actually financial aspects. So if I going to share data to other, what is my benefit? And another point, in many places, we have seen the appreciation. If I am using your data, I should appreciate it, and I should mention it somewhere that this is the owner of data is that organization. So maybe this 2 to 3 point is more important for sharing data.
Okay, thank you. So I will first talk about why we don't share data. And I think that he mentioned one of the things that I wanted to talk about policies and also guidelines that are streamlining data sharing. Sometimes we don't have the perspective and the right guidelines as to how this data needs to be shared and who to share and where the data moves and how the data will be used after the data has been received. Sometimes they say that it will be used for X, but then you realize the data is being used for Z, and it doesn't bring trust for people to. And number two, from technical perspective, you can see that people wish to share data, but data have been collected that are not meeting standards. So it becomes very difficult to share. You feel that organization A should move data to B, you feel and wish like doing, but the standards are not the same. You push the data, they can't receive the data. You receive data is gibberish. It's not meeting. So if standards are well implemented across organizations and systems, I believe that data sharing wouldn't be anything difficult to go by, because most institutions have guidance and policies already, but they are not implementing and enforcing those standards for us to be able to share data easily. Now to the panelist question. Looking at the health data governance that we talked about, I would like to find out how the various countries are protecting their data. How do you store this data? Do you do something like off the shelves? Do you do in-house something or cloud services? How do you protect or how do you store this data? Since health data is very sensitive and it's something that most countries cherish not to move outside their country. Thank you.
Thank you. We also have a couple of questions received, maybe. Okay. Who wants to take that? Countries.
So in terms of how we store, I think the kind of solution architecture that you're talking about. So we have several different types of centralized health data repositories in Malaysia. So one is, I think I brought Malaysian Health Data Warehouse a few times during the presentation. So this is one of the main core data sets that we have in Malaysia, which is our routine kind of healthcare data that we collect during admissions and outpatient visits. So this was actually developed by a vendor, but it's actually owned by the Ministry of Finance, Malaysia. So we worked using kind of open standards, and then we kind of customized the different kind of the way we manage the virtual patient identifier, how we store the PIIs. We kind of customize it to our need, but also we ensure that we comply with all the ISOs regarding international security kind of guidelines. But in terms of how we control the data, of course, there are many different checkpoints that we have in the data warehouse. So for example, when you want to log in, there's multi-factor authentication. And then when the data is stored, then you store the personal identifiers and all the clinical and demographic data separately in different databases, assigning pseudonyms to the different records. Of course, when we design the data warehouse, we had to think a few years ahead because it was going to be the integration point of the different hospital information systems and clinical information systems. So it was more like a kind of homegrown solution for us. And now with cloud technology and everything, so we are exploring new ways to do it because it's much easier to kind of assign, primary keys and foreign keys when you're managing traditional relational databases. But when you go to cloud, it's a whole new challenge.
To answer to your question, I think I'm just talking on behalf of Malaysia. Of course, there was also this issue, public cloud versus private cloud versus on-premise and so forth. But I think right now we are fine with data on a cloud. But I think the issue is, where is the data center? I think that is the issue, whether it's offshore or inland. And also, if it is health data or very sensitive data, then it cannot be in foreign land. So that is the debate that is going on now. And Malaysian government has also recently signed the cloud policy framework with the three main players, which is AWS, Google, and Microsoft, and also one local data host cloud provider in the country. So most probably these three main players will also build their data center in Malaysia to host any data. So that is what's going on now.
Okay, one question that has come from Mongolia, Dr. Zoe, if she's around here. Oh.
Hi again, Johan from National Health Service of Ukraine. And I want to put you a few steps back and ask one question. When we talk about health data, it's not only about citizens' health information. We have tourists, permanent people who live in our countries, and some of them, like people from the European Union, have their own legislation about data protection, like GDPR in Europe. And do your legislation in your countries have points about foreigners, or how do you provide services and collect their data in your countries? Thank you.
Yeah, we had one experience actually with GDPR and a local registry. So we consulted the foreign partner and also our legal team, and the this sort of the advice was, if there is a foreigner, for example, a European that is actually included in the registry, then GDPR kicks in. Meaning the guidelines under the GDPR will now be applicable to our jurisdiction. But if there is no foreigner in the registry, then there's no case, no concern. So it's actually when a particular foreigner that has a particular separate data protection law, and I think if both countries actually have sort of agreements on that, then the GDP, or in this case, the GDPR actually is applicable in our setting. I don't know to what extent that can be implemented, no, but that was the legal advice that we had regarding that matter. Thank you.
Okay, I have a question for the panelists. So this came from Mongolia. What are the pain points that health informatics personnel and ICT experts shared during the in-country dialogues? This is to Dr. Udita.
Thank you. Actually, the health informaticians and the ICT staff were the ones who were, moderating and encouraging the discussion among the participants. What we were focused on was the stakeholders that participated from the other administrative areas. But of course, we do have pain points when it comes to health data governance also. Of course, like what we have, the main problems we have is the knowledge and of the staff that are handling the data. Because sometimes people are very careless when it comes to handling health data in their systems, right? So most of the data collectors are not technical people. They are not fully aware of the implications of some casually disclosing some information between others. So one of the main things that we want to highlight is to try to impress upon them the seriousness and the responsibility they hold when collecting patients' data, and that has to be built into their training, I think, and that is one of the most important things we have to consider.
Thank you, Udita. One more question is, where does cybersecurity play in health data governance ecosystem? Anyone wants to take that question? Anyone from the audience? Where does cybersecurity play in health data governance ecosystem? Means I'm sure that this should be anyway part of the governance. That's for sure. There's no question about it. But then, is there any particular role it has to play, or where? The question is where does cybersecurity play in health data governance ecosystem?
Yeah, Elvin.
So I think if you look at the COVID 2019 framework, security is a process after managing risk. So technically, when you do health data governance, you're actually trying to understand the environment and assessing the risk of maintaining your data within your institution and sharing data with another institution, whether it's government or another health facility. So cybersecurity definitely is within the health data governance spectrum, but it follows a risk management exercise, because from the risk management, you understand what cybersecurity measures you need to put in. And to answer the question about who is responsible for securing the data in your facility. So I work in 2 hospitals, and we are mostly composed of health professionals who know nothing about how to secure databases. So we outsource this to qualified, competent vendors
bound by an enforceable contract. We know that these vendors are capable of securing the database for us. Finally, for the Philippines, I don't know if Dr. Dennis already shared it, we have the Data Privacy Act, which is patterned after the data protection law of the UK, where we have personal information controllers and personal information processors. And data can only be shared. To answer the question of Dr. Fazila, why can't we share data? It's because we have a law that states it can only be shared if, one, there is transparency, meaning consent of the data owner, there is a legitimate purpose, it is expressed explicitly what is the purpose of sharing the data, that should be knowledgeable to the data subject, and third, that it should be proportional. We are just sharing just enough data for the purpose stated in the legitimate purpose. Having said that, I think the quick answer to the question of why can't we just share data is we cannot share data if there is no health data governance. I think that's the quick, short answer to, because it's easy to share data. You just download it on a file and email it to somebody. And I think that's what we're trying to avoid. We're trying to avoid arbitrary, indiscretionary, non-consented sharing of health data. And the only way we can prevent that is if we all, as policymakers, step up and basically start our health data governance journey. It's not going to happen overnight. And thank you, Transform Health, for starting this journey with AHIN 3 years ago. It will take time because it's not just about policies, it's all about cultural, cultural aspects of making sure that everyone understands what data governance is all about. Thank you. Manisha.
I just want to add to him. I feel that data is ultimately responsibility of the data fiduciaries. Whether you have a very good contract and a strict contract with vendor, but ultimately it is responsibility of the data fiduciaries, the collectors of the data who have taken data from patient with their trust. So just
I agree.
adding it.
So even if we outsourced it to the vendor and something happens, the hospital management is accountable. The vendor, we will sue the vendor, but in the end, we are completely accountable to the patients if there is a breach. Thank you.
Thanks. Maybe this one question for Christine. For this year's World Health Assembly, you had a side event on the Transform Health HDG. What is the plan for the next year's World Health Assembly?
Thank you. Yeah, so this year, I was going to say last year, it was earlier this year, saw that really strong political support for this agenda, and we don't want to lose that momentum, and that's why we're building up this work and engaging, having these different discussions. But again, that needs to move somewhere. And like I said earlier when I spoke, that ideally we want to see a set of minimum considerations endorsed by governments through the World Health Assembly. Great if it was at this one. That means, though, ensuring that health data governance is on the agenda in the first place of the World Health Assembly, and that comes from requests from governments to put it on the agenda. And then within that discussion topic, then a discussion and agreement around a resolution around a minimum set of considerations. So that's the aim. We are working, as I said, in bringing together all these different ideas from these different consultations to feed into a draft document for further consultation. And again, going back to what I said before, it's very much governments need to be in the driver's seat of this. What we're trying to do through this process is to help catalyze and support that process, but then to kind of take it forward to the World Health Assembly. That ultimately needs to be the leadership of government. So the request to all the governments in the room and those beyond is to really kind of take this and drive it, work together around what, share your experiences, but then also where are the gaps and what is needed to really work together to take it forward.
Just wanted to add, the Ministry of Health Sri Lanka, as well as the Department of Health Philippines, had written to the WHO earlier this year and in support of the agenda of health data governance, and then also to evolve a global framework. So maybe if there are any Ministry of Health officials here who could also say, like, you could go back and then work on this. Also, you could also propose, like you heard the 3 countries sharing. I'm sure that, many of you would also like to work. So if any other country would like to do this in-country dialogues in the coming months or in the early next year, so feel free to tell us right now so that, we could see if we can plan something together with Transform Health and then help you facilitate that. So that's one thing. And then, like, if you want to also write to the WHO in endorsing this agenda, please feel free to do. I think there is a process that each country follows. I think it's typically from the MOH, the International Bureau or the division within the MOH actually writes, puts across the request as part of either the executive board meeting or the World Health Assembly agenda or the regional consultation. So I think there is a process. So please feel free to share if anyone else from the ministries from other countries who are interested in doing that for your countries, especially the in-country dialogues, because that is something that AHIN can work together with you and then make it happen, just like how these 3 countries shared the experience today. Any other country who is interested to do this dialogue, let us know so that we can put this in our plan.
No need to raise your hand today, but you can approach any one of us, and we will help you and assist you. Thank you.
Actually,
Pradesh has got something to say.
the in-country dialogue, what do you mean? And this is the country-on-country dialogue? In-country dialogue?
Yes.
What do you mean?
Okay.
Country to country?
Yes, we can explain. With these 3 countries, so we have a TOR defined, like who could be the different stakeholders that could be involved, and at the end of the consultation, what is that is expected. So we could, for example, from AHIN, we can share those draft agendas as well as the reports with the consent of the 3 ministries, which is here, Sri Lanka, Philippines, and Malaysia. So we could share that in such a way that, for example, you may already have some policies or regulation in your country that may or may not directly relate to digital health or health data. So if you are in the need of such a regulation, then you could conduct this in-country consultation by which you could bring in variety of other stakeholders who have a say or who are, I would say that, for whom health data is relevant. So you could call them and then have a discussion. Like we could share the agenda, like what was being done in the 3 countries with their permission, we could share it with you.
Can you communicate with you later on?
Can you repeat that?
Can you communicate later on?
Yes, of course.
Yes, yes.
We can sit together and
Okay,
discuss.
no
Yeah.
problem.
We
We'll
could do that.
communicate.
Thank you. Anyone else? And then, any other questions, or you feel that as a region, like we could work together on this topic and do something more meaningful? Please feel free to welcome. Yeah, share the inputs.
Is there any other questions or comments from the floor? Yes, go ahead.
Yeah, hi, I'm Dr. Fida Mehran. I'm from UNICEF Bangladesh. So a more kind of a basic question, in fact. So what we've seen in many places is that there's a sort of a, I would say, fragmentation or a division between the entities or the governance bodies that deals with data and the governance bodies that deals with programs. Because the programs have been around for decades and decades, and the data is over the last 15, 20 years. So, so governance-wise speaking or policy-wise speaking, so in the 3 countries, or maybe even I can get a general answer, that will be fine. What is the best approach from the government to maybe sort of bring it into practice, or sort of bring some sort of approach that can engage the program people with the data people, so that there's a number of different things that we've seen in Bangladesh, because there's a lot of different data reporting systems. There are a lot of paper registers, and which becomes overwhelming burden. And I've seen that Malaysia also reported around data over collection. So we collect more data than we can use. And on one side, there's a lack of data collection because we don't have enough HR. And these are system bottlenecks that are constantly hampering the data part. And so in order to approach and address these system bottlenecks, what is the best approach to take from the policy side so that we can sort of get that kind of buy-in, that kind of engagement from the program side on a sign of similar enthusiasm, so that we can system ready, but we don't have the program components and HR in place. So what can be the best holistic approach to do that?
Okay, let me share like what I have. I think the first thing is to sensitize the policymakers. Tomorrow we will be talking something about the gaps work that we have done, the regional call for action. And then this is where like we actually work with the ministries of health in the country, the representatives from the Ministry of Health in countries. And then we have identified some priorities in terms of the governance, architecture, program management, standards and interoperability. Similar to that, this is a topic I think no government can run away. So I think sensitizing our policymakers is probably the first step. And then show them what is in it for them. Because ultimately the government is there for the welfare of the people. And if somebody is able to get access to healthcare better by sharing data, the right data being available at the right place at the right time, I think if that can be a selling point, like usually in every government during the election manifesto, there are many things like a common minimum program and there are many promises. But if we can sell this data governance related to health and then the benefits, if that can be sold, I think it will work. That's my take, but then like over to the other panelist here.
Yeah, perhaps one example would be the CDCs, the Centers for Disease Control, wherein the epidemiological data is actually made use by the programmatic team to be able to address that particular finding from the data. In the Philippines, we still don't have a Center for Disease Control where there's a current bill to set it up. But what we have seen in other countries with Centers for Disease Control is that there is that mutual benefit, at least between the team that is actually doing the epidemiologic survey or epidemic data, and the program people who actually has the programmatic response to a certain disease. So that kind of relationship probably could be one example of where data can be utilized by the program people to address a particular health concern.
I think in Malaysia, I think during my presentation earlier, I spoke about the National Health Informatics Committee. So on the government side, what we have there is that we have representations from all the different programs, and we actually sit together with the more technical side. So we have the IT personnel, the Health Informatics Center as part of the planning division, and that is the platform that you can actually negotiate and to actually identify those informational priorities as an organization, rather than have solutions being deployed in a piecemeal basis, dependent on special funds, especially ones that are not completely sustainable. Because some of these programs, they may work on, they may work with international funders who would come in, provide certain amounts of money, and then after the program ends, they don't have enough sufficient funds to actually last, for the information system to last. So that is one of the major challenges that we have. Sure. And that's our way of rectifying it is by having a strong kind of leadership structure.
Okay. I would like to ask a question about the data architecture. When we design the data architecture, most of the time it's either centralized or decentralized data architectures. They have advantages and disadvantages. A long time ago, we design a centralized data architecture, but from our experience, many recent design they tend to become decentralized data architecture. My question is, according to some kind of considering about the health data governance principle, what is the the directions?
As part of the health data governance principles, I think one of them is they actually propose that countries consider federated data architecture. And I think it was a really good discussion point because in Malaysia, the kind of national health data infrastructures that we have are mostly centralized. And then we realized that this may not provide sufficient controls, especially at the facility as well as regional government levels in terms of, because parts of the process are devolved into the different subnational kind of regulatory bodies. So I think this is why we brought the point that some of the participants in the workshop, actually they looked at their current practice and think that this is actually a good idea for us to consider implementing in the future.
Thank you. I think if there are no more questions, I think it's time for us to wrap up. So one last chance if anyone wants to ask, otherwise we close. Oh, okay.
Good afternoon, everyone. I'm Kalipun and I'm from Nepal UNICEF Country Office. Maybe I want to go back on the question of the data sharing in terms of SDG. Because when we're talking about the data sharing, largely we are, concerning and we are talking about the within the partners and within the sector related to the health only. Because health is, the largely affecting by the other program and sector also. For example, education, was climate change and the emergency and every the other program is affecting to the health programs indicators and the data. So I just want to know that how these three country is sharing the these health data to other sectors, other department of their different, maybe the different ministry to design, to plan, or for the proper budgeting, so that the health programs, the health sectors data that support to improve the health sector's data and the program. So that is my question. Thank you.
Well, I'm not sure in other countries, no, but usually there is silos, no, of data, or even within a particular sector. An example would be weight monitoring in the Philippines, for example, no, when a baby is born, the data is in the health unit, no. When it goes into a preschool, no, when the child goes to a preschool, it goes to the social work. And then when it goes, when the child enters elementary and high school, the data is with the Department of Education. The main, and then when you go to college, it's with the university. It's only after probably college that the data goes back primarily into the health sector. So there are, I'm not sure how it all started, but there are different institutions and processes with these institutions that actually make data sharing actually also difficult, even within national programs or policies. One example wherein that I think that has been that we have been trying to sort of integrate that is through conditional cash transfer in the Philippines, no, wherein the data for receiving the benefits from the conditional cash transfer, the families receiving the conditional cash transfer will have to show their health data, their education data, and social work data. So the integration is not driven by the health sector, but driven by the social protection context. So probably the integration of data now that are being sort of compartmentalized could be done through probably a broader developmental program, which can actually probably, in a sense, force data integration from the context of social protection.
Thank you, Dr. Dennis. I think we are at the point where we can close the session. And then thank you all for the participation. And then I would like to thank the panelists here, Dr. Udita, Dr. Hamad, Kristen, Dr. Dennis, and Fazila. I think we had a good discussion, and then I'm sure that we will have a lot more to do. And then tomorrow being the main conference session, I think we can also get back and then get ready for many more things to come in the next 2 days. But before I close, I would like to ask one of the panelists or any one of them if you want to share any take-home message, just one of them, and then I'll call upon my colleague Anis to come and share the summary, and then we close for the day. Any closing remarks, fellow panelists? Okay.
Just one very quick that I think a number of points actually I noted down that came up a lot from the national dialogues and the discussion afterwards, but two I think that I want to highlight that I think are really critical in this discussion is around the accountability piece of it. And while legislation and regulation provide that accountability, it needs to go also further than that, because that ultimately provides those avenues for redress if people or organizations working for different communities feel that the data isn't being protected in the right way. But I think we need to go also further when considering this and strengthening the regulation of having those accountability mechanisms as well. So the processes through which people then can hold those responsible accountable. So I think accountability is one really key point I think that's been coming up. But then coming back to the point of trust, I think a lot of this all comes down to trust in the health system and in the data system, where people feel that their data is being protected in the right ways, but that they also then come back to the point of data sharing, feel comfortable sharing their data so it can also then be used to improve health outcomes and public benefits. So accountability and trust within the data systems, which ultimately is the reason for the need for stronger regulation and legislation.
Thank you, Kristen. That reminds me, just a few weeks back, I was in a workshop, like involved with conducting that on responsibility in AI, because people are talking about responsibility AI. But we felt that there has to be responsibility in AI in the sense like, and then during the discussion, there was one particular comment, I really liked it. They said, there cannot be responsible AI without an accountability fixed in place. So I think for that, like having data governance is inevitable. So that's how I look at it. And then now, Anis, if you are ready to share the summary, we can close the session. Okay, anyone else?
Yeah.
Please. Yeah, sorry.
I think the key word here is governance. And when we talk about governance, we talk about relationships, between the one governing and the ones being governed. And I think a lot of the discussions is actually looking back at that relationship as it is, in a sense, probably modified or influenced by health and data. But it goes back to that basic relation between the ones who are governing and those who are being governed. So I think the context of a rights-based approach in terms of looking at governance could actually be it has been already there, but probably be highlighted in the further discussions. Thank you.
Thank you.
Okay, lastly, before we close, before we pass it to Anis, we know health data is actually a strategic asset, and having a proper governance is very crucial. So I hope everyone here, as a country, how would you use the principles that has been shown by Transform Health as a building block to further build on it, to have your own data governance principles? I think it's very crucial. Thank you.
Thank you, Fazila. I think I request Anis to summarize.
Thank you very much, Jai.
Thank you
and
very much.
Fazila and all the participants.
Yes.
Applause for them. So we are closing the first day of before the day of the conference. So we have passed several pre-conference sessions. Okay. We have passed all the fruitful session in the pre-conference. In this room, we have AI for health insurance. We discussed a lot about the potential AI to support health insurance. In the next room, we discuss about the digital health roadmap in Indonesia after the current blueprint. And in the morning, we also discuss the WHO team provide overview of global digital health certification network. In the other room, CISU, the country health information systems supported by USAID in Indonesia, also discuss about interoperability and also data standard. And also other team from the group of CDC Geeks, they also have an interesting program on strengthening the digital health competence, especially to support the communicable disease group. So I think we started with a very successful event for this pre-conference because of the coming of all the IHIN friends in Jakarta today, and applause for all of us today. And we expect a more successful event tomorrow. We heard just recently the Minister of Health will come. So it is a very good opportunity for us to share about the initiative, the collaboration between countries in Asia and also Africa, and we could share to our minister, but with some changes. So given that the minister will drop to this hotel before he goes to the parliament, we need you to come earlier. Is it okay, right? Previously, the minister will start the session on 9:20, but given that he has a time only 9 to 9:15, we expect you to register earlier and come to this event at 8:30. Is it okay? Okay, good. So that we will have the session tomorrow start earlier. Prepare your breakfast so that we can come this room earlier and prepare before the minister coming to this session. But given that we need also you also to have the registration bags, everything ready, for the international participants, please register yourself if possible tonight at 6 to 8 in the Rama boardroom in the second floor. You can meet our IHIN team. We can prepare the bags and ID card, especially for the international students. You can bring the bags, and you can also bring the bags before shopping. So at least to buy something, there is a bag to put something to buy. So for international participants, please, you can register tonight. For the national participants, given that there are also more requests for the last short notice local participants, we give opportunity to register as well tomorrow. So thank you very much for your coming attendance, participations. We receive a lot of questions through HOFA. For those who are not yet installed the apps, please do. And please join the session and continue our network, our friendship. And tomorrow we could continue the discussion and share with other countries. I think this is to conclude our session. Thank you very much for your coming, and see you tomorrow for the opening IHIN GM 2023 in Jakarta. See you.